Let's start with environmental emergencies. So this will cover only heat and cold related emergencies. So let's start with heat. There are two heat challenges. We have dehydration induced by heat, which we call heat exhaustion. And then there's also true medical emergency, which is heat stroke. Difference between the two is in the severity. In heat exhaustion, as already mentioned, this is simply dehydration caused by extreme heat. By extremely heat, we have two conditions here. It can be either non-exertional, meaning heat waves, say temperatures hit 3 digits in summer, or it could also be exertional, wherein the patient is running a marathon, or doesn't have to be a marathon, could be a rally outside under 3 digit temperatures, or just a ordinary day but have been out in the sun too long without adequate hydration. Either way, the patient becomes dehydrated due to extreme heat. We call it heat exhaustion. So manifestations will be what? Manifestations of dehydration. Okay, so heart rate's high, blood pressure's low, mucous membranes are dry, oliguria, okay, moist, clammy skin. Okay, so dehydration basically. And labs will show the same. High hematocrit, high hemoglobin, high BUN creatinine. The temperature, of course, will be 102.5 or higher. This typically does not reach 103. Okay, so around 102.5, 101, around that area. But the patient here is is responding to heat reduction mechanisms, meaning once we take them out of the sun or we fan them, for instance, or we give cool compresses, the patient's temperature responds, the temperature drops. Okay, that's the difference. In heat stroke, that's a different story. Please read on your own chart 67-6. This is now prevention, how to prevent heat stroke and also heat exhaustion. They are self-explanatory. Okay? I mean, keeping hydrated. What would be the best fluids in this case? If you're outside and it's hot, would water be the best option or? Okay, so hard water will be better. Something like Gatorade, vitamin water, things like that. Those beyond water, things that contain electrolytes. Okay, because they're better absorbed, and of course they're healthier. Okay, I mean they're more beneficial compared to just plain water. In case you get more prevention or avoiding heat exhaustion, heat stroke questions, the answers will be here. Meaning who are at risk for heat stroke or heat exhaustion. They are, of course, the very young, very old, people who work outside, meaning utility workers, first responders, including cops, nurses also, if you're in the home health field, okay, so you are also at increased risk. Now, people with chronic conditions, especially those that affect the very systems that we need to compensate, meaning drugs that affect our kidneys, our heart, and our lungs, because we need these three organs to compensate, right? During dehydration or during extremes of temperature. So patients taking tranquilizers or other CNS depressants, those taking Xanax or lorazepam, alprazolam, or anticholinergics because these cause drying, yeah? Diuretics, same thing, and then beta blockers as well. The thing with beta blockers is what does the drug do? It blocks the compensatory response. Yeah? Meaning, what do we need when we're dehydrated? We need we need the sympathetic response. Yeah, we need adrenaline, we need epinephrine. But then when you're taking beta blockers, what is the effect? You're suppressing them, okay, which is not good. People who are homeless, for instance, or with mental health disorders, okay, they're especially at risk. Okay, they're not really in the right mind to take shelter or make the best judgments, for instance. The elderly, very common. So even though they are institutionalized, doesn't mean they're not at risk for heat exhaustion or heat stroke. How often do nursing home patients actually ask for fluids? Like, hey, can you get me some juice, some water? No, especially with those with advanced, moderate to severe dementia. They are no longer aware, right? They have agnosia. So they don't have the sensory perception that you and I do. They don't feel thirst. You give them food or water, they don't know what to do with that. Okay, because they don't know what it is. They have agnosia. They can't recognize, they see that it's water, but they don't know what to do with that glass of water. Or you give them a plate of food, yeah, that looks like food, but they don't know what to do with food. Okay, that's called agnosia. And we have natural disasters as well. Let's say the grid comes down, okay, no power, then of course air conditioning is gone, and then that puts our institutionalized population at risk. So that's just not for long-term care. That also includes prisons, yeah, psych mental health facilities, or assisted living facilities, or juvie institutions, all the institutionalized facilities. Assessment, the patient with heat stroke, again, the difference between heat stroke and heat exhaustion. Yes, all heat stroke patients start with heat exhaustion, but then with heat exhaustion, the patient no longer responds to heat loss mechanisms. They may still sweat, but most people with heat stroke, no more sweating. What is the purpose of sweating? Why do we sweat when it's too hot? So we call that, we have three heat loss mechanisms. Yeah, we have evaporation, we have radiation, we have conduction. Four actually, we have convection. Yeah, so they no longer respond to any of those mechanisms. Okay, they continue to increase the body temperature. Plus, they are dehydrated at the same time. Now, because of this, the brain cannot tolerate temperatures over 104 degrees. Since these patients' temperatures rise 105 or higher, there will now be confusion. So, does this complicate the patient's prognosis? Yes, because now can they still have the presence of mind or the consciousness to get out of the heat or do some interventions to cool themselves? Not anymore. So the bizarre behavior, the mental status changes here, the acute confusion increases mortality with heat stroke. Again, this tells you here usually anhidrosis, okay, usually don't no more sweating, but there are still heat stroke patients that still sweat. So it's not really a diagnostic finding. Does that make sense? Meaning you can't just say, oh, that's heat stroke because there's no more sweat. Okay, so that's not really the defining diagnosis. It's really the mental status changes. The other manifestations here are related to the dehydration, the electrolyte imbalances, which has that hypotension, tachycardia, tachypnea. Management. First step is, of course, take the patient out of the heat. Okay. Cool them at the site. So let's say most of these cases are outside, with a few exceptions if they're in a nursing home. But either way, you start cooling the patient. That's our first intervention. And depending on the patient's mental status, if they're still conscious and can follow commands, then we give them cool liquids to drink. If not, then we'll have to wait for EMTs to establish an IV access, and then we give them IV fluids. Yes, depending on the patient's blood pressure. So what do you think? A good question. So what do you think the first IV fluid ordered will be? Will it be ISO, hypo, or hypertonic solution? Okay, we start with ISO, which are, give me examples of ISO. Saline or LR. Okay, so those two will be your first choice. Maybe 1 liter of that, and then afterwards will depend on the patient's labs. Uh, Usually, if it's a true dehydration from heat exhaustion, then it will be hypotonic solution. 0.45% will be administered. So as far as cooling, how do we cool the patient? So first is evaporation, yeah? So we take off the clothes. Of course, the clothes may either be wet from sweating or it could be dry. Whichever is the case, we remove clothing to allow for radiation and evaporation. And then we do conduction. Okay, we put cold compresses. Don't use ice. Okay, just cold compresses. And then we have convection. You can use fans or put them in an air conditioned room, for instance. Okay, so those are our heat loss mechanisms. So you got, sorry, the problem with ice, as long as it's not in the whole body. Okay, so yeah, so just the what do we call those? Yeah, the hot points. Is that the? I think that's the term. So only in these areas, okay, but we don't need to um submerge the patient in ice because that can actually trigger shivering, and then now we got more heat production. When we say ice though, these are ice packs, okay? We do not submerge the patient in ice. Okay, so we can do, typically we don't need to do internal methods of cooling. By internal, I'm referring to cool IV fluids or putting in rectal tubes and then instilling cool water into the rectum, or putting in an NG tube and then putting cool water into the stomach, or inserting a Foley and then putting cool water into the bladder. Those are internal cooling methods. It's not really necessary for heat stroke. Okay, they usually respond to external cooling. The rest of the interventions will depend on the degree of dehydration. If the patient has severe hypokalemia, for instance, then they may go into cardiac arrest, in which case we do a CLS, which is not covered by the textbook. Now, the seizures may follow because of severe heat. The brain cannot tolerate, like I said earlier, temperatures above 104. So at that point, febrile seizures will occur because of increased intracranial pressure. Because what happens to the blood vessels in the brain if you have a high temperature? Will there be vasodilation or vasoconstriction? Vasodilation. So what happens to the volume of blood in the brain if you have vasodilation? Increases, right? So what happens to intracranial pressure? Rises, and then seizures will follow. Doctors may institute preventive, um, meaning prophylactic seizure precautions, meaning they will order levetiracetam, which is Keppra. So they know the patient's at risk for high risk for seizures. Rather than waiting for the seizure to happen, we will administer anti-seizure medications. Okay, so we'll do that ahead of time. Sometimes the doctor may order benzodiazepines as well, prevent seizures. Yes, once the temperature goes over 104, so 105 or higher, we institute seizure prophylaxis. Okay, we already said fluids of NS or LR. Are these patients in AKI? Pre-renal, intrarenal, or post-renal? Pre, very good. So since they are in AKI, we put in a Foley to monitor urine output. Plus, if it's exertional hyperthermia or heat stroke, if it's exertional heat stroke, most likely there is muscle damage, from, let's say it was a marathon of some sort. So there's also rhabdomyolysis, which can cause intrarenal AKI. Okay, so we already talked about anticonvulsant medications. Again, that could either be levetiracetam, or they could also order benzodiazepines. Again, AKI management, including dialysis if necessary, electrolyte replacement. Okay, so diazepam or lorazepam. You still remember these drugs, yeah, from last semester? Okay. And as already said, this may be used to prevent shivering during the cooling process. Best way, however, is of course to prevent this from happening in the first place. I worked for a rehab facility. Basically, it's a nursing home in Florida. It was called Citrus Health and Rehab. It was very nice. They had, first of all, they had wooden floors, no carpet anywhere. It looked like a house. They had puppies at the desk. They were, like emotional animals. They bring the puppies to the rooms for uh, residents who cannot ambulate. So they were all, what's that breed? No, they're small. Mm, Yorkie, yeah, yeah. So the she wasn't the manager, but anyway, that's the one of the staff bred them, and then she sold them to the facility. So the facility bought the puppies, and the puppies live there. It's a 24-hour facility, so perfect. Okay, so the puppies are, I mean, some of them are old, but I mean they're puppies forever, right? So it was like that, and then they had beverage carts. So what the beverage cart looks like was it was a cart, and they had no, yeah, like an umbrella. So it looks very festive, and they had all sorts of beverages there. They had water and then all sorts of juices, and they literally went into each room. They're small enough to fit into the room, and then they served them. And then, of course, the staff, whoever was ruling that, they had a costume, and then very festive again. So they offered drinks, and that was done throughout the day. So they go into patients' rooms. If the patients cannot go out, no, they say they're bedbound. And then, of course, there's another cart only for the day room. So in the day room, they serve beverages all day. So they had very little to no cases of heat exhaustion. And this is Florida. very hot all year long. So if we had all that, then we wouldn't have to deal with, you know, and they had good reviews because the quality of life was better for the residents. Before we go to frostbite, let's do another heat-related injury first. This time in another emergency. So one of the complications of anesthesia, particularly general anesthesia, is malignant hyperthermia. This is rare though. So what is malignant hyperthermia? This is a rare inherited muscle disorder. This is induced by anesthetic agents. What anesthetic agents? They're listed here. So the drugs known to cause or trigger malignant hyperthermia are halothane, enflurane, isoflurane. There are also a few. Ensoflurane also does the same. And the muscle relaxant succinylcholine. So 1, 2, 3, and 4. Succinylcholine is not a general anesthetic. This is a muscle paralyzer. See, when we do major surgery, say using a general anesthesia, can we allow the patient to move around on the table? No, you have to be completely still. Will the patient cooperate if they're unconscious from anesthesia? No, because they're not aware, right? So we have to paralyze the patient. So we give them succinylcholine so the patient stops breathing. No muscle will move. So every muscle in the body is paralyzed. That's why they are intubated. Okay, so when we use general anesthesia, you are intubated, you're on a mechanical ventilator. You follow? Okay. Now, so these are the necessary drugs we need. So anesthesia, you're told to count 10 backwards, 10, 9, 8, and then that's it. Okay, so in 3 seconds, you're unconscious. Then we give you succinylcholine, you're paralyzed. Then we intubate you. Okay, put you on a ventilator, and then we start cutting. Of course, you're also given opioids because we assume you're in severe pain, so you're given opioids at the same time. Now, this is inherited. So therefore, comes in families. This is really serious. It has a high mortality. So the best way to approach this really is prevention. We do not screen everybody for this gene. It's expensive. Plus, is it really frequent? No, extremely rare. Who works in the OR here? Or anywhere near the OR? Know somebody? Okay. So if you do know some OR nurses, you can ask them, do you guys have a malignant hyperthermia kit? The answer will be yes. And if you ask them, where is it? Yeah, it's somewhere there. Have you ever used it? Chances are the answer is no. That's how rare this thing is. Okay, so there's just a few people that have the gene. For lack of a better term, we call it they have the malignant hyperthermia gene. Again, screening is impractical because it's expensive. And again, not too many people have this gene. So prevention is in the interview. So whoever's doing the pre-op checklist, which is going to be you potentially if you work in med-surg. So you're going to do the anesthesia checklist. So a bunch of questions, routine questions, have you had surgery, blah, blah, blah. So when you get to anesthesia section, the first question will be, have you or a family member ever had general anesthesia? If the answer is yes, next question that pops up will be, have you or a family member ever had a reaction to general anesthesia? If the answer is yes, that is an alert for the anesthesiologist. And what is the anesthesiologist usually gonna do? Are they gonna use these drugs? No. It doesn't matter what the patient's response was to the next question, which is what was the reaction? And sometimes some facilities don't even bother asking that because once the answer is yes, we assume it could be malignant hyperthermia. You understand? Okay. So therefore, once the answer is yes, surgery will proceed. We just won't use these drugs. So you may wonder, why not get rid of these drugs? Again, the condition is very rare. These are the most cost-effective general anesthetic agents and muscle paralyzers in the market. They're the cheapest and they're widely used. Okay, so all we can do again, if the answer was what? Yes on the question of have you or a family member. Why is it you or a family member? Because it's genetic, okay? It's inherited. So it could be not the patient, but it could be a parent, a grandparent, a child, okay? Other triggers which are not really common are these medications, okay? But they're possible, okay? These can trigger malignant hyperthermia, but most cases that are documented are these general anesthetics and this muscle paralyzer. Are we clear? All right, let's go now to what exactly happens. So here it's a muscle disorder. What happens to the muscle is they start contracting. The problem is they won't relax. So the every muscle in the patient from head to toe will contract. And what will happen if your muscles are contracting? Let's say you do this. Let's see what happens to your body temperature when you do this. Okay, so it's just one arm. If every muscle in your body contracts, what will happen? Whole body will generate heat, and the temperatures here can reach 111 degrees. How much temperature do you need to cook an egg? Yeah, 111. If it can cook an egg, can it cook your brain? Yes. Can this cause death? Yes. Now, despite the term malignant hyperthermia, the hyperthermia actually is a late sign. So if a patient dies from hyperthermia, that means, did we do our job correctly? No. Okay, so let's go to the pathophysiology. So what happens is, upon exposure to those anesthetic agents and succinylcholine that I mentioned earlier, muscles start contracting. The earliest sign, let's go to manifestations now. The earliest sign are cardiovascular respiratory. That means the heart rate is the first that will rise. Why did the heart rate go? Why did the heart rate go up? What were those muscles consuming? Every time you contract your muscles, what will they consume? Oxygen. So once oxygen levels drop, what will happen to the heart rate automatically? Will suddenly rise. So first sign, early sign, tachycardia, heart rate greater than 150 is the early sign. Next is the unexplained drop in oxygen levels. So if oxygen levels drop, what will happen to CO2? It will rise. So the earliest now, remember, this patient is intubated, yeah? Because this is general anesthesia. So who will be the first one to notice? The anesthesiologist will see this first. Unless the anesthesiologist went for a potty break, in which case the circulating nurse will be manning the anesthesia chair. So it will be the circulating nurse that will report this. Okay, so nurse will report sudden tachycardia, and then they will report also the CO2 because we intubate the patient, so there will be a CO2 sensor at the end of the AT tube. We call that the end tidal CO2. So if the end tidal CO2 rises, that means oxygen levels drop, correct? Can CO2 and O2 both be high at the same time? No, it's always paradoxical, right? Oxygen rises, CO2 drops, CO2 rises, oxygen drops. So again, the earliest sign is what? Tachycardia, and then so the respiratory early sign will be CO2 rise or oxygen decrease in oxygen. The other manifestations, of course, one's tachycardia, because really, if you think about it, it's the hypoxemia, right? That triggered all of these. So once the muscles start contracting, they consumed all of the oxygen in the body, oxygen drop, CO2 rose, and then the heart rate automatically increases. And then, of course, blood pressure will drop and decreases oxygen, blood flow to the kidney. So there will be oliguria. And then if we don't do anything, because once those muscles contract and never stop contracting, will those muscles survive? They'll die, right? And then what will those muscles again release when they're dead? Myoglobin, right? Remember rhabdomyolysis under heat stroke earlier? So there will be rhabdo here. So can the patient go into AKI? Yes, so two types of AKI here. So we have pre-renal plus intrarenal because of the rhabdo. And what other things will the dead muscle cells release besides myoglobin? Potassium. Okay, so will there be hyperkalemia? Okay, so take your pick now. Where do you want to die from? The AKI, from intra or pre-renal AKI, hyperkalemia, or from hyperthermia? Okay. So the management will be, of course, addressing those three. Because the patient will die from AKI, they'll die from hyperkalemia, they'll die from hyperthermia, cause brain damage, and then cardiac arrest, of course, from hyperkalemia. Again, the rise in temperature is a late sign. So once the temperature rises, did we do our job? No, because once we see the reaction, we spring into action. Remember that malignant hyperthermia kit I mentioned earlier? Okay, so we have that kit. It's on standby. It's in every operating room suite. They just grab the kit. All they need to address malignant hyperthermia are in that kit. Now let's examine what could be inside that sterile kit. All you need to address those three. So let's take it one by one. So for the oxygen, of course, it will be the anesthesiologist. Okay, so we'll increase oxygen. Can we stop surgery? If possible, yeah, because the bad thing about malignant hyperthermia is it can occur anytime. It can occur right after we gave the anesthesia. It could occur a few minutes after or hours into surgery, or it could also occur after surgery. When do you think is the best time for this to occur? Okay, right at after anesthesia induction. So as soon as we put the mask on the patient, gave them the anesthesia gas, if it occurs right there, that would be the great. Okay, because we haven't cut the patient yet. So it would be the best time for this to happen. But unfortunately, we don't know when this will happen. The first thing we'll do is grab the kit. We give the drug that's in there called dantrolene sodium. Dantrolene sodium is given IM or IV. This is a muscle relaxant. This is also used in multiple sclerosis, all other conditions that have muscle spasm. So this is a potent muscle relaxant. So for malignant hyperthermia, though, this is the only FDA approved drug to stop malignant hyperthermia. Okay, so no other muscle relaxant is approved, only dantrolene sodium. So this is what you'll give first. So the anesthesiologist will grab this, administer it to the patient. This will stop the reaction. However, did the process already start? Yes, the patient's muscles have already started contracting. So were there also already myoglobinuria, myoglobin in the blood? Was there already potassium? Yes, they're already there. So the other interventions we need are, how do we lower potassium? Calcium gluconate will be in that kit. What else? How else can we lower potassium? Bicarbonate will be there too. Yeah. Will there be insulin with dextrose? Okay, well, insulin probably not, but dextrose will be there. So you have to grab the insulin, regular insulin from the medicine cabinet. How else? Well, this is severe, right? This is acute, so those will be our intervention. So those will be the first drugs we will use. Are we going to insert a Foley if there's not already a Foley in? Yes, we need a Foley. We need to monitor, yeah, kidney function. And can we start cooling the patient down? Yes, remember every muscle here. If you've seen videos, if you watch YouTube, malignant hyperthermia, the videos you'll see is if you raise any part of the body in this patient, let's say you lift an arm, that arm will stay up. That's how rigid the muscles become. You raise the leg, that leg will stay up, even though the patient is unconscious. That's how stiff the muscles are. Okay, so you can just imagine the amount of heat that the muscles are generating, okay, and then how much oxygen they are consuming. Okay, so it's for them to contract like that. So that's all in the it says cart, but it's actually just a kit. Okay. Um, so hopefully the patient survives. Okay, so we give fluids. Of course, we start cooling the patient down. Now the IV fluids, the saline or LR that we'll be infusing will be wrapped in ice. We'll put ice bags around the IV fluid bags so that they're cool when they enter. So that's internal cooling. If necessary, or if the temperature is really high, of course, we put ice already on the axilla groin, but we will start cooling the patient down. So if these measures keep the temperature still high above 110, we lavage the stomach. So we put in NG tube, put cool water into the belly, and then suck it back out. And then do the same in the rectum. And if needed, we'll also put in a three-way Foley. That way we irrigate the bladder with cool water and then drain it out at the same time. So these are our internal cooling measures. So we're cooling the patient outside and internally as well, because we can't risk brain damage. Okay, because the temperature again will reach 111 or higher, and that's not good. Yeah, again, the triggers are these drugs listed here, but extremely rare. Yeah, a few of my friends are OR nurses, and when I ask them, they've never seen it happen. Extremely rare. Why do you think it's extremely rare also, the events? I mean, there must be a lot of, there has to be malignant hyperthermia gene positive patients out there, but how come the cases are so low? What did we do again? No, what did we do to prevent this? We ask questions. Okay. So the only cases that we miss would be someone who had no idea. So let's say I don't know my patient's history. Okay. Plus, if you think about it, if this patient, let's say you had malignant hyperthermia, will they tell you about it? I mean, you survived, right? They did that. Yeah, probably. But I mean, you're out of surgery. Will you remember? No. You can care less. Is that what happened? Okay, go back to sleep. Right? But they will put it in your allergy record. What do you think will be listed in your list of allergies? These drugs will be put in your allergy list. And that you will, of course, will be told you're allergic to these. Okay, you have the malignant hyperthermia gene. We can't use these. Okay, so that will be in your permanent record. That next time you have surgery, will they use this? Okay, hell no. Okay, because you're lucky to have survived it, right? So make sure it never happens again. Any questions on malignant hyperthermia? Very good, children. Let's go to cold related now. Let's start with frostbite. I know hypothermia first. And then we'll go back. Since frostbite is here, let's start with that. Okay, frostbite. Um, who are at risk for frostbite? You know what frostbite is, right? I mean, the temperature so below freezing, of course. The temperature outside is 32 degrees or lower, and somebody will be exposed, a body part will be exposed, unprotected. Okay, so most common parts of the body will be the nose, yeah, so fingers, the nose, the ears, right? Those are usually the exposed body parts. Or if it's your cheeks, then the cheeks will also be exposed. Your toes and hands are also equally high risk. So here, feet, hands, nose, ears. Now, there are different degrees, just like in burns, wherein we had superficial, right? First degree, second, third degree, fourth degree. Same thing with frostbite. It also has degrees. So the first degree, we most commonly know it as frost nip. Yeah. So you and I probably experienced frost nip. We didn't cause any permanent damage. When we go out, let's say, um, temperature 10 degrees or below, you've been out like that without any gloves, how do you feel? Okay, the hands are very painful. Yeah. The fingers get really painful. Your nose are very painful. And then when you go inside away from the cold, you turn red. Yeah. You can see that your nose, your hands are very red. So that's what we call redness and erythema. So you had experienced frost nip. Of course, the second degree, third degree, or fourth degree frostbite will involve other colors now. Okay. I had a patient 3 weeks ago. He fell from the bus, sustained a head injury, and then experienced frostbite. Okay, so three of his fingers on the left hand, actually here, the thumb, the forefinger, and the middle finger, all black. Right? So just a few minutes after he fell, because he was on the ground for a while, okay, while they called EMTs and picked him up. So he had frostbite just from that one fall. So you see, and he was 85 years old. Okay, so how fast it can go? I mean, how long was he there? Just maybe 10-15 minutes, right? EMS should be there at that time already. But that's how he got the frostbite. Okay, so that's how fast it can set in. So number of factors, his mental status, the temperature outside. Okay, so perfect, perfect combination. So let's go with who are at risk. Is it any different from what we had for heat related injuries? Same. So same um, mental health patients, homeless people, institutionalized people, our utility workers, okay, first responders. Hmm? Oh yeah, okay, very good. Sports, just like the marathon athletes we had also for hyperthermia or heat stroke. So same risk factors. Prevention, how do you prevent it? So with heat related, we said, have cover and then maintain fluids, right? So here you dress. Okay, so do we dress like a lot or in layers? Okay, let me ask you this. How many socks should you wear? With socks, though, think about it. The more socks you wear, what will happen to your It's okay if you're not wearing shoes or boots, but once you put on multiple layers of socks and put them in a boot, what will happen to circulation to your feet? It actually causes constriction. Okay. So multiple layers of clothing, but there should only be one layer of socks, because the more you wear, it actually causes constriction because our boots designed to be worn like that? Like you have 2, 3 layers of socks? They didn't design it like that. Okay, so the fit will be different when you have one sock versus multiple. Okay, what material will be best? Is cotton the best for hot and cold, or is it the synthetic material? Vortex is now the best, yeah? Non-cotton, because what will cotton do? Especially in cold, it'll absorb moisture and then what will happen? You have wet socks because you were wet and then exposed to cold, it will freeze, right? So it's not really good. Whereas if you have Gore-Tex or similar material, moisture wicking material, they do not retain moisture. Okay, so they would be the best. So you notice it, right? If you buy ski gear, what are they made of? Are they really, is there any cotton in those things? No, if they have cotton, maybe 10, 20% cotton. Everything else is polyester, spandex, yeah? So moisture wicking material. Okay, that's the modern technology now. Probably in the 80s, 90s, no, we had nothing but cotton, but not anymore. So we've got moisture wicking technology now. Let's go to management. So just like in heat-related injuries, what's the first thing you do? Okay, take them out of the cold. Okay, get them to a warmer place. What will we do with any wet clothing? Okay, take them off. Put warm clothes on. If there's anything constricting, not only clothes but jewelry, especially. So what will happen to the frostbite again? Just like in burns. What did we do with the jewelry? Burn clothing. We remove them. Yeah. So remove them as early as possible. Yeah, once we have that available. Okay. Do you know what she's talking about? That's a warming blanket. Okay. So we have equipment in the hospital. Of course, we don't see that in the field. We have them in the hospitals. Okay. So we have warming equipment. One is a bear hugger, which blows warm air into the, yeah. Or we can also have cooling blankets, which double as warming blankets, meaning these are same as bear huggers, but instead of blowing hot air inside, we're circulating water inside. So that water can either be cool or warm, because you can adjust the temperature on the machine. So you can either increase the temperature of the water or lower the temperature. So depends on what you want to use it for, cool the patient or warm the patient. All right, so we remove clothing. If the lower extremities or even the hands are involved, of course, we try not to use them. We don't want to, put additional pressure, which further compromises circulation. And then we do rapid rewarming. Now, the rule here is if, let's say, if there's a chance of refreezing, what I mean by that is we have a frozen hand, obviously. It's frostbitten. If there's a chance wherein once you start rewarming, meaning you thawed the extremity, right? It's now thawed, it's not frozen anymore. And then there's a chance that it could refreeze. So what circumstances am I talking about? Let's say we're up in the mountains in the middle of ski season. That's where the accident, someone fell off, okay? So in the buried in ice, okay? And then we carried them out, we dug them out, and then we put them in a tent, we rewarmed, and then during transport, so let's say the transportation was not really ideal. Okay, so let's say it wasn't, it was very windy and it's a pickup truck, for instance. Okay, so or any other condition wherein when transporting the patient, you expose the patient again to freezing conditions when you've already thawed the extremity. So look at steak. So steak shouldn't be frozen, yeah? You should be eaten fresh, yeah? So let's say you got a sale, which what I do, there's a sale in steaks. I buy in bulk, freeze them, and then thaw them once, eat. What if you froze, thawed, and then refroze that steak? What will happen to it after the second freeze? The meat is ruined, yeah? It doesn't taste good anymore. Same thing with our hands and feet. So body tissues, the same. It was frozen, you thawed it, now you froze it again. That will not recover anymore. That body part is now gone. Okay, they will have to cut that off. There's no more chance for recovery. So here, look at it's hot, right? 104, that's hot. That's hot water. So that's what we use, 98.6 to 104. If you want to see how hot that is, just put your hands in your finger in your mouth. Your mouth is about 98, 99 degrees. Okay, so that's how hot it is. How much more? 104. So we do that for 32-minute spans. And by the way, another rule is we give analgesics, okay, because it's painful when you thaw a frozen body part. And the pattern that we use is if the patient's whole body, so let's say it's not frostbite, right? So let's say it's hypothermia with frostbite. If that's the case, meaning it's not just one body part that's the problem, it's the whole body, the patient is hypothermic, we warm the core first, we warm the trunk, okay, and then we warm the extremities afterwards. Meaning your target is the core first. They call it an after drop phenomenon. What does that mean? If you warm the extremities first, meaning the blood warms up, right? But if the core is still frozen, once the warm blood returns to your heart, meaning to your core, it cools down again. So therefore, is it really? No, you'll have what we call an after drop. Okay, so the key there is warm the core first, meaning the trunk, and then you warm the extremities. But this one obviously is local, correct? Because this is frostbite. So one body part is involved. So that's why we can immerse just that body part in the rewarming bath. Yes, the patients can go into cardiac arrest, but that's more for hypothermia though, not frostbite. Because when we say frostbite, we really refer to a body part, usually the hands, the feet, the legs. So no, that won't have any uh, you lose that limb, but not really your life. Okay, let's put it that way. No massaging though. Okay, so just handle it carefully, rewarm it. And again, once rewarmed, protect it from further injury, including refreezing. Okay. Expect swelling though, so control the whatever you cover it with. Okay, not too tight. If there are blisters, just like in burns, don't pop them. Okay, just leave them alone. Then you attend to the other problems. So same thing as what we discussed in malignant hyperthermia, since that involved muscle injury too, right? So in frostbite, yes, there's muscle injury. So we expect rhabdomyolysis as well. You expect hyperkalemia, etc. And since these are deep wounds, then the patient will be given tetanus injection. Okay, if we have, just like in burns, so if you have any compartment syndrome that results, then we do escharotomy, fasciotomy as indicated. You avoid further substances or medications that will cause vasoconstriction, such as coffee, tobacco. Okay. That's it. Let's go to hypothermia. So this one, cold-related injuries, risk factors again, the same. So older adults and very young as well, infants, chronic illnesses, diabetes, heart failure, COPD, kidney disease, homeless people, and we have hypothyroidism, spinal cord injury, meaning they have decreased mobility. Okay. Prevention, we already mentioned earlier. Let's go to management. So similar to heat-related injuries, what did we do? Remove the clothing, yeah? So in cold-related, of course, obviously that's why they're cold-related because the clothing are either wet or cold. Remove that, replace them with dry, warm material. Usually when we have hypothermia, this is outside, yeah? So the patient is outside unless, again, remember in Texas when they had that winter storm and Ted Cruz went to Cancun. Yeah, that part, no power, and then people had freezing temperatures. Okay, so we had many cases there of hypothermia, especially the elderly. So ABCs, just in case there are other injuries, or I should say CAB, sorry. And then same effect, the patients will have severe cardiopulmonary complications as a result. If they do go into cardiac arrest, we change the rules a little bit because how long can you do chest compressions? Let's say somebody goes into cardiac arrest, how long can we do chest compressions? Yeah. This time though, we go longer. Okay. So if we normally do maximum 30 minutes and then we call it, yeah, about 30. But most cases, I mean, because if you look at the algorithm, if it's 5 minutes apart, 5 minutes apart, so technically we should stop compressions around 20 minutes. Do you know what I'm talking about? Let me show you the by the way, you can do ACLS even without your license yet. So let's say after school ends, you can go for ACLS. Okay. Most facilities reimburse you for the cost if you're worried because it costs like $250. Um, okay, let's look at this one. I'm just giving you an idea about how long a code will last. So let's say, okay, so you call a code. Yeah, patient is unresponsive, no, not breathing, no pulse. So you start CPR, right? So let's say, what time is it now? 2:07. Okay. So how long? So let's say you do 2 minutes. Okay. So look at that, 2 minutes compression. Yeah. So 2 minutes, and then you put the pads on. So let's say 2 minutes later, we got VFib or VTAC. So we shock. Okay. So shock, no matter here, these are the rules. So if you have shock over them, you do this. If here we have rhythm, came back. Okay, so this is obviously shorter, but this one would be the longest. So you've got 2 minutes here. Okay, so 2 minutes, 2 minutes, that's 4. Another 2, 6. Yeah. And then, but look at the medication. You can give the medications repeatedly every 3 to 5 minutes. So let's say we go 5 minutes. So after the first shock, you give the first epi, right? So that's 5 minutes already. And then every 5 minutes, you can repeat the epi. So that's already what? 10, 12 minutes, yeah? And then you can give amiodarone here. So that's 15. So all in all, about 25 to 30 minutes. Okay. We miss it sometimes because, in the heat of the moment, Sometimes the recorder, because there's supposed to be a recorder. I'm usually a recorder because I mean I'm in bad shape. Okay, I can't do I can't do chest compressions. Okay, but I'm just at the cart. Right, I'm recording and I'm handing out what they need. So you know the protocol, so you know when to give epi. Okay, so you expect it already. So once they start compression, so I take out the first epi, I put it together, and then once they ask, okay, epi, all right, here we go, and then I record, right, and then 5 minutes later, I don't want to open anything because what if the rhythm comes back and then we stop the code, right? Yeah, we're gonna waste it. So anticipate, okay, nothing now, so I start preparing the next one. All right, so I anticipate, okay, second epi, all right, and then keep recording. Sometimes whoever that person doing that tend to do other things and then they forget the recording. Okay, so it should be like if you're a recorder, that's your job. Okay, so it's important job because you're keeping time. So you're telling the providers, hey, 5 minutes already. Okay, because sometimes they forget to ask. Okay, so 5 minutes already. Oh, okay, give another epic. Okay, you hand it. So it's about what 30 minutes, right? 25, 30 minutes. Now in hypothermia, we extend the time beyond 30 minutes because if the patient's hypothermic, the heart was kind of well not frozen but kind of preserved because it's cool, meaning the metabolic rate is lower, right? So the rule is if the patient's temperature is below 94, no, between 85 and 94 degrees, meaning hypothermic, yeah, they're not dead. So they're only dead once they reach 95 or higher. Does that mean? Does that make sense? Meaning you're not dead until you're warm and dead. Does that make sense? Yeah, so you have to be at a certain temperature and still no heartbeat to be dead. So if you're below that temperature, below 95, we continue, okay? Because you're not dead yet. Do you follow? Okay, so we extend, that's why we extend of course, people, there's already 5 or 6 people who have taken turns already. So if we remember the cooling measures, internal cooling measures we did in malignant hyperthermia. Okay, so instead of using cool, now we use warm. So we wrap the IV fluid with hot water. We warm it with hot water packs, and then same thing with our lavage. So instead of putting cool water into the stomach, we use warm water, and then same thing for the rectum, same thing for the bladder. Okay, so we use internal and external cooling measures. So here, forced air warming blankets. This is the bear hugger that Ms. Nolasco was referring to earlier. And here's the after drop phenomenon I mentioned earlier. Okay, because that cold blood from the extremities contain a lot of lactic acid. Okay, so that can cause arrhythmias. Okay, so what's the rule again? What's the pattern? We warm the core first before the extremities. Okay. Any questions?
In terms of warming the solutions, do you have a specific temperature to warm it up to?
No, just wrap it as long as it's body temperature. Body temperature is what, 90, 98, 97, yeah. Okay. But remember with frostbite, we can go as hot as 104. Okay. Of course, you don't use the microwave. Okay, don't put the IV fluid bag in the microwave.
I'm going